Hello, everyone, and welcome to Heads Up, the weekly podcast of the National Headache Foundation. This is Dr. Lindsay Weitzel, migraine strategist, founder of the Facebook group Migraine Nation, and chronic daily migraine survivor. I am here with Dr. Vincent Martin. He is the director of the Headache and Facial Pain Center at the University of Cincinnati, and he is also the president of the National Headache Foundation. Hi, Dr. Martin. How are you today?
It's a pleasure to be here.
So we have an awesome topic for everyone today. We are going to talk about refractory migraine, and we're going to do a three-part series. This is the first part. We would like to talk about why we have it, the best ways to treat it, how to get rid of it, triggers, etc. And Dr. Martin has 24 years of experience of treating people who have migraine. And we're going to go through how he approaches patients with refractory migraine. So let's first just talk about what you consider refractory migraine, because the definition is not, really solid out there. So what do you consider someone who has refractory migraine?
Well, there's no definite diagnosis that's been formally established for refractory migraine, but usually it's when a person has chronic migraine, which is 15 or more days with headache, of which 8 or more are migraine. And in many cases, it's where the headache is daily and continuous, and people have failed 4 or more preventive therapies in the past. So it tends to be a really refractory patient population, and one that we see very commonly in a headache practice.
Right. Okay. How do you approach a patient? What do you look for first?
Well, I take a very, what I would call trigger factor approach to patients. So being both a headache physician and a primary care physician, I'm kind of looking for what might be triggering the headaches in that person. And there are certain things that are more common than others. One, for example, is the neck and in the nerves that go from the cervical spine, which is the spine where the neck is, into the back of the head, called the occipital nerve. So when people have a location of their head pain that primarily is in the back of their head, then I'm thinking, could there be a trigger from the neck?
Right.
And in those situations, I might refer people to physical therapy on their neck, or we might do nerve blocks of those occipital nerves, which are the 2 nerves in the back of the head. So we might block those nerves. And that may help either temporarily, or it may help for longer periods of time. But if it helps for any period of time at all, even if it was only for an hour, or even if it was only for 30 minutes, that might suggest that nerve could be involved in the pain. And then you might need to do serial nerve blocks, for example. Another example would be as if the neck was really restricted in motion, like they can only move it a certain way, the amount, then I might, if physical therapy had failed after 4 to 6 weeks, we might do an MRI, a special kind of x-ray of the spine, of the cervical spine, which is once again, the spine and the neck, looking for pathology. And in certain instances, that if there's a disc herniation, we may do something called epidural steroids. So we basically start kind of focusing in on the neck and on the back of the head. And we're primarily trying to relieve neck pain, but oftentimes when you get rid of the neck pain and the pain, that'll help the pain in the back of the head. The other important thing to note is that sometimes disease of the neck can radiate up into the forehead or up into the top of the head as well. So it's not always localized to the back of the head. So that's one trigger. That's the neck/occipital nerve trigger.
Okay. What about the jaw area? A lot of people have TMJ issues. Do you focus on that area?
Well, once again, I look at the location of the pain. So if a person's pain is primarily localized in the temple, I'm thinking about different things as well. So one thing is temporomandibular joint disorder. That's a joint that when you open your mouth, you can actually feel this joint here. And that's a joint that is used obviously a lot when you chew, develop arthritis and other derangements of the joint. And that can also occur, that pain in that joint can occur at night because people grind their teeth. And then you'll get pain here or maybe even up here. But commonly people have TMJ, when they open their mouth, they'll feel a popping in the joint. Sometimes the range of motion might be restricted of that joint. and the pain's localized here. So the treatment for that would be to see a dentist who's an expert in TMJ. A lot of times they'll give you a bite block to wear at night, and they'll do some physical therapy on the TMJ joint that can help that as well. And then rarely, if it's really severe, there may be some surgical options as well, but that's not something we commonly deal with in headache patients in terms of surgery. And then there's a third trigger too that
Can I interrupt? I wanted to ask, you're pointing at these places that are sort of on both sides or up here. Do a lot of these people actually present with migraine, even though they're pointing at various parts of their head?
Yeah, the patients are usually having migraines,
Okay.
And also daily headaches that could localize into those regions. So the migraine pain might localize here,
Okay.
or if you have a daily headache that maybe doesn't meet migraine criteria, maybe it localizes, say, in the temples, or localizes in the back of the head.
Okay. Yeah, I just wanted to point out that the different pain may vary, and it may vary by day, and you can have migraine, and some of these triggers can be making your problem worse. So sorry to interrupt. So I think you were going to move on possibly to rhinogenic problems.
Yeah, rhinogenic problems are usually problems with the nose, and that usually happens with allergies or air pollutants, where you get some inflammation in the nose. And it's possible that, say, an allergy, let's say you're allergic to cats, or you're allergic to, say, tree pollens that occur in the spring. But what happens is that when you inhale those, the nose and the sinuses are lined by the trigeminal nerve, which is involved in migraine. And that inflammatory condition that results in the nose can activate the trigeminal nerve. And in that situation, the pain tends to be localized to the cheekbone. It might be localized to around or behind the eye, or might be localized up to the forehead or even temple. So often people will have a location of headaches. Kind of, it's almost like a mask that you put over the face, and that can be from a trigger from the nose. Now, what's interesting is that it can either directly activate the nose, or the nerves in the nose, or it could cause so much nasal obstruction that you can't breathe through it. Okay. And then you can imagine what happens at night when you can't breathe.
Right. So
if you can't breathe through your nose and you're lying flat, and so forth, you can start to snore. And then in some cases, you can develop obstructive sleep apnea. And they've actually found that if you give nasal steroids, they're little nasal sprays in the nose that have steroids, that you can actually improve sleep apnea in people that have obstructed breathing at night. So there are a number of different things. So if I think somebody's got a trigger in the nose, and I think it's an allergic trigger, there's certain nasal sprays and nasal antihistamines and nasal steroids that I will prescribe. And the nasal steroids, there's one study where they looked at nasal steroids and found that they were able to reduce the pressure that people often feel in their sinuses during an allergy season. So I would often do that. And then along with that, there are some people that have a sinusitis, so an infection of the sinuses. And sometimes those infections can be chronic. So you can have them for long periods of time. And sometimes that can trigger headache and make patients refractory as well. So there are times where you'll actually investigate the sinuses with a CAT scan to make sure that there's not some trigger in the nose or sinuses, or particularly an infection that could be triggering headaches.
Okay. So all of these things can cause localized pain within themselves, and they can also trigger migraine. Is pretty much the point of what we're saying. So you kind of have to get to the root cause in order to treat it, correct?
Exactly.
Okay.
And in addition to that, there's also other nerves that can become entrapped. There's a nerve over here called the auriculotemporal nerve, where if you touch over the nerve, sometimes that can become entrapped. That can cause pain in this location. We talked about the occipital nerves back here. They can become entrapped and cause pain in the back of the head. Sometimes you can get entrapment of nerves directly over here, the supraorbital or supratrochlear nerve as well. So there are a number of different things I'm looking at when I'm seeing a patient with refractory headache, where I'm going to kind of target these. Because if you think about refractory headache, it's almost like you're down to the last 3 minutes of a basketball game. You got to put a press on. So you got to do everything you possibly can to try to help get rid of these headaches, along with medications. We haven't really even talked about those, but oftentimes with refractory headache, you've got people on 1, 2, 3, 4 different meds, as well as doing these other things we talked about with identifying triggers to have a maximal improvement in people with refractory migraine.
Right. I think this information is so important because I think we so often hear people who say, I know that it's not my sinuses because my headaches get worse when I look at a light. Well, maybe that's not true. Your sinuses could have started the problem or triggered the problem, and you also have migraine. Or they'll say it the other way around, that they know it's migraine and it's not something else. Well, we can have a few problems going on at the same time, all making the other ones worse. And I think that those are things we just take a step back and look at when we have a headache every day and we have migraine so often. So I think that this information is hugely important. So I'm so glad we were here to chat about it. Is there anything else you'd like to add on this particular part 1, where we're talking about sort of triggers that are up here in our head for refractory migraine?
I would just say this is, and this kind of sets the stage for some of the other podcasts that we do, is that when you have refractory migraine, your threshold for triggers goes way down.
Right.
So you become more sensitive to all these different triggers. So all this next stuff may not ordinarily trigger a responsive headache, or the TMJ that you have may not normally cause headache. But
Right.
when you have refractory migraine, all of a sudden you're much more sensitive to every trigger, whether it be a trigger in the head like we talked about today, or some of the other triggers we're going to talk about in other podcasts.
Right. All right, great. Well, thank you so much. And everybody have a great night. And we will see you next week on Heads Up, the weekly podcast of the National Headache Foundation.